Hello, everyone. We are just letting people in from the waiting room. This is the Time for Genetics webinar. If you're looking for that, you're in the right spot, and we'll get started in just one moment. All right, welcome to Mountain States Regional Genetics Network's Time for Genetics webinar. We still have a couple more people coming in from the waiting room, so I'm just going to get started with a couple of announcements and let everybody come in and get ready for our webinar today. Our webinar today is on the genetics of pediatric seizures and epilepsy. And our funding for this series of webinars comes from HRSA, Health Resources and Services Administration. If you're interested in more about that funding, you can visit hrsa.gov. Today you have myself, Christy Weiss, as the projects manager, and Jamie Stefanski as our state teams coordinator, joining you to host this webinar, and we are here for assistance. So if you need to find us, you can message us in the chat. Just a couple Zoom logistics before we get started. We are asking everybody to stay in mute during the webinar so that we can have a great call quality and everybody can hear. We do ask that you can leave your video on or off, whatever you are most comfortable with. We are recording the webinar today for archival purposes. You can see the active participant list there, and if you are looking for the chat for technical issues or for the question and answer session, you can find that at the bottom here at number 4. We do ask that if you have questions during the presentation that you put those in the chat, and if there is time at the end, we will get to those questions with our speaker. This webinar is part of a series that is with our program called Time for Genetics. Time for Genetics is our pediatric primary care genetics education initiative on the 8-state Mountain States region. We have had 3 cohorts that we've recorded. You can see those colored pins there on the map in orange and yellow and blue, and we have 28 clinics participating across our region. If you or someone you know might be interested in this program, please feel free to email me. We will be entering our last topic area in December. If you're new to Time for Genetics and would like to catch up on some of the other topics that we've explored in this series, you can scan this QR code and go to our library. We've looked at things like red flags, developmental delay, Ehlers-Danlos, genetic testing, autism, cerebral palsy, and newborn screening. And any of those marked with an asterisk still have CME available for the webinars in that series. And we'd like to invite everybody in just 2 weeks from today to our Genetics Summit happening virtually and free of charge to anyone who would like to attend. You can scan this QR code, or you can go to the Mountain States website at mountainstatesgenetics.org and click on the banner to register. We're really looking forward to have 12 amazing sessions on all sorts of genetic topics coming up in just 2 weeks. So please join us for that. We do also have continuing education still available from our last year's summit, and you can find that as well on our website. With that, I'd like to let you all know that we do have CME accreditation for this webinar today, and we will be offering CME for physicians, physician assistant CME, CNE for nurses, and CPE for pharmacists. An evaluation link will be provided at the end where you will be able to claim your CME credit, and those will be processed in the coming weeks, and you will receive an email with a link to your certificate from Projects in Knowledge, our CME provider. Our speaker today does not have any financial relationships to disclose. And it is my distinct pleasure to introduce you all to Amanda Sandoval-Karamian, who is an assistant professor of pediatric neurology and epilepsy at the University of Utah and Primary Children's Hospital. And she is here today to talk to us about this topic, genetics of pediatric seizures and epilepsy. And with that, I will turn the mic and the presentation over to her to present to us today. And again, if you have any questions, please note those in the chat. Dr. Sandoval, it's all yours.
Great. Thank you so much for that introduction. I am going to hope this screen sharing works again. Let's see. Let's do a slideshow and switch these. Okay.
Perfect.
Does that look great. Right?
It looks great from my end. Thank you.
Okay, wonderful. All right, then I will go ahead and get started. Again, thank you for that introduction. I'm Amanda Sandoval-Karamian. I'm one of the epileptologists, pediatric epileptologists at Primary Children's in the U of U, and I have a specific interest in early life genetic epilepsies. And I'm really excited to present this important topic to you all today on the genetics of pediatric seizures and epilepsy. Again, I have nothing to disclose. So the objectives for this session, by the end of this talk, I hope that you know the definitions of seizures and epilepsy, understand the basics of genes and genetic testing, understand the differing yields of our genetic tests that we can do specifically for epilepsy, and know the incidence and prevalence of genetic epilepsy, as well as recognize common genetic epilepsies by age of onset. So we will hope to accomplish that all in the next hour. So just as a background, seizures versus epilepsy, because I feel like this can sometimes be a point of confusion. So a seizure is a single event, and it's defined as a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Epilepsy is essentially a seizure disorder, and we see here in this box on the right, this is the ILAE definition, or the International League Against Epilepsy, which is like a big governing body and makes a lot of guidelines for epilepsy and seizures. And this is a relatively recent 2014, relatively, I'm dating myself here, recent definition of epilepsy. Historically, it's always been two unprovoked or reflex seizures, reflex like photosensitive seizures, things like that, reading epilepsy, that occur more than 24 hours apart. But then this was added in this updated definition where you can have just one unprovoked or reflex seizure, but a high probability of further seizures, at least 60%. That's similar to the recurrence risk after having two unprovoked seizures. And that means like you have an abnormal EEG with epileptiform abnormalities, you have a known structural lesion or a structural lesion that we discover on MRI, which puts you at a higher risk for having additional seizures. Or you have a diagnosis of an epilepsy syndrome and you're cured of your epilepsy if you've been seizure-free for 10 years with no seizure medicines for 5 years. And epilepsy is a major chronic health condition. It affects 1% of the general population. It's a big problem worldwide and in the United States. There's 3.4 million people in the United States living with epilepsy. And of those, there's over 1 million people with uncontrolled epilepsy in the United States. If we think about just children, and specifically under 14-year-olds, there's almost 500,000 children in the US, and there's a big kind of based on population of where people live, but we can see in our region here, relevant to this seminar, we have tons of patients with active epilepsy in our state, in our states, I should say. And SUDEP, sudden unexplained death in epilepsy, which is something we all are kind of afraid of for our patients, of course, and is relatively rare, is still a big problem, and it occurs in 1 in 1,000 people with epilepsy. Now kind of transitioning over a little bit towards genetics. So there's lots of different seizure types, and you can have any of these different seizure types in genetic epilepsies. So kind of thinking about it in the most broad categories, there's focal onset versus generalized onset, awareness, like intact versus impaired awareness. But you can have motor seizures, non-motor seizures, absence seizures, with lots of these genetic onset or genetic etiologies of epilepsy. And then just at the most basic level, thinking about genes and like the genetic structure of DNA. So there is DNA in all of our cells. So every cell of our body has genetic material in it. And the kind of biggest division that we see of that, well, is the nucleus, right? With the nucleolus in the middle. But the chromosomes, which we can see with the karyotype, and we can look at kind of like the big structures, anything put together wrong, is any big pieces missing. And then we look a little bit more in detail with a chromosomal microarray of are there any like smaller pieces missing or added. And then you see this DNA gets kind of nicely unraveled and we get to our genes here, all the way down to just single base pairs within, or nucleotides making up the base pairs, I should say, which we can test with molecular testing for single gene disorders, next generation sequencing, gene panels, whole genome, whole exome sequencing, which I'll get into a bit more in detail. So the karyotype, again, tells us kind of most broadly the number, the size, the shape of the chromosomes, which is important because there are certain disorders like ring 20, ring 14, where the chromosome actually forms, like sticks to itself and makes a little ring. And the only way you can test for that really is with the karyotype. But it can also give us large deletions, duplications, translocations, inversions. So it gives us kind of a big picture overview of the genes. Then the chromosomal microarray can tell us if there are smaller deletions, duplications, which are known as copy number variants. And there's lots of copy number variants just in the general population that aren't disease causing, but we're really specifically interested when we're thinking about seizures and epilepsy and those that are related and associated with epilepsy. Then there's epilepsy gene panels. Again, so gene panels are essentially just lots and lots of genes that are all related to one kind of disorder. So there's gene panels for lots of different types of disorders, but specifically focused on epilepsy. We think about epilepsy gene panels, of which typically there's about like 300-ish genes that we test for on panels currently. And that is targeted next generation sequencing, which simultaneously analyzes multiple genes at the same time. And we can look at, to some degree, some deletions and duplications, but also really like single nucleotide changes. Then there's whole exome sequencing, which takes a bigger look at the genes. And so essentially we're looking at all of the coding regions of the DNA, the exons. So thinking about the gene, you have promoter regions, exons, introns, then it gets transcribed into RNA with just the exons and introns. It gets spliced with all the introns removed and then translated into the amino acids in the protein. And so the whole exome is really just looking at the exons, which will make up, this mRNA. But it doesn't look at these introns, versus the whole genome sequences everything, essentially all the exons, all the introns. And that also, both of these actually use next generation sequencing. An advantage of whole genome is also that it can identify copy number variants, where exome is a bit more limited in identifying copy number variants. And so when I explain the different genetic tests to patients, I use the analogy of a book or an instruction manual a lot of times. So when we're picking different tests and talking about different tests and costs and things like that, I explained that the human genome is like an instruction manual. And so there's instructions for basically everything in your body, everything about you, in your genes on some level. The karyotype is like the basic look at the table of contents. Is everything there? Is it in the right order? Is anything big missing? Then the microarray is going to look for changes in Paragraphs, sentences, words, is anything missing? Is anything extra in there? The gene panel is looking for spelling changes in words, but only about a specific topic, about the specific topic of epilepsy. Takes out all of those sections and looks through them to see if there's any spelling changes. Then whole exome sequencing looks for spelling changes, but only in the main parts of the story. So we're not looking at everything, but we're looking at a lot of the story. But the genome, on the other hand, looks for spelling changes, changes in paragraphs, changes in sentences, and that's looking cover to cover, essentially. So I like using that because I think it's easy for patients to visualize kind of what we're talking about with different tests. Oh, did I skip one? No. And then something else to consider is that the way that we interpret the results, it does depend on the inheritance pattern of the gene. And we'll talk a little bit more about inheritance versus de novo, and it doesn't necessarily, the fact that a gene is autosomal dominantly inherited doesn't necessarily mean that it came from a patient. It's often still de novo, but the impact of that gene acts in an autosomal dominant way. But kind of at the most kind of highest level, there's autosomal dominant. So essentially you only need one kind of change in one of the alleles of the gene because there's two alleles, two copies for every gene. You only need one of the copies to be changed in order to be affected. There's autosomal recessive, in which you need two copies of the gene, so both of them need to be affected in order for you to have the disease. There's X-linked inheritance, which is essentially just transferred usually from mom to boys, or boys are more severely affected if this X-linked process can affect boys and girls. And then there's de novo, essentially, where it's a new change in the patient. And most of the genetic changes resulting in epilepsy are actually de novo changes, meaning they're not inherited. But there are like important exceptions to that, which we'll talk about a little bit. And so when we get this genetic testing, how do we interpret the results? So when I'm talking to patients about, even before getting the testing, which is important, I think, to set up expectations and for everyone to be on the same page about what we can expect in terms of return of results from genetic testing. I described that there are three kind of main categories with buckets of results that we can get. There are positive results, meaning that of all of the genes we've tested, and if we think about it for a panel specifically, like an epilepsy gene panel, because that's one of our more common tests that we get, or start with, I should say, that we found the answer for the epilepsy. We think this is the genetic cause of the epilepsy, and it explains the clinical picture well. So that's a positive result. There are negative results, essentially, where in all of the genes that we tested, there are no pathogenic variants. There's not even any variants of significance or likely pathogenic variants. There's just no kind of notable changes in the genes that we've tested for. That doesn't necessarily mean that there isn't a genetic cause. It just means that it's not one we quite understand how to test for yet. And then there is a really big bucket, variants of uncertain significance, or VUSs. And that essentially means that there's a change in a gene, that another change in the same gene causes epilepsy, but we're not exactly sure what this change does. We don't know what the clinical significance of this change is. And there's lots of different things that we could do to try to reclassify and better understand variants of uncertain significance. One of those is family testing or familial testing. Often in gene panels, there'll be complementary parental testing for some of these variants to try to clarify them. Often when we're sending a whole exome or a whole genome, we'll do it as a trio. So we'll send the patient and the parent samples with them. Of course, can't always do that, but that's the ideal way, so that we can tell, even before, getting the results ourselves, we understand, like, okay, this is maternally inherited, paternally inherited, and there can be further classification before the results are even returned. And so when we think about family testing and parental testing, if the gene is inherited, if the variant is inherited from an unaffected parent, it's much less likely to be the cause of the disease for the patient because the parent is not affected. It may just be like a population level variant that's not fully understood yet. But still something to think about in terms of like the penetrance of that variant specifically. Then there is, of course, the clinical phenotype. So let's say you have 5 VUSs, 3 are paternally inherited, 1 is maternally inherited from unaffected parents. So you've knocked out 4 of them. You have 1 left that you're not sure about. So you think about the clinical phenotype. So looking at other reported cases of pathogenic variants of that gene, does it fit the clinical picture of your patient? So if it's like your patient has a very benign epilepsy, they're overall doing well, and all of the patients described have like terrible infantile onset refractory epilepsy and like horrible development, then you think, well, that doesn't really fit. I don't think this is really the cause or explanatory. Of course, as we learn more and more about genes, we know that there's a lot of phenotypic variability for variants in genes. And so it may be that that is the explanation. We just don't understand enough about it yet. But we can say like, you know, this doesn't really explain the clinical picture. The phenotype doesn't fit. So I don't think this is really the cause. There's also functional and biochemical studies where you can essentially through lots of databases, a lot of this data is already available for the variants in the genes. And for that specific variant, there are predictive models for like, do we expect it actually to disrupt protein function? And if the answer is no, then that's probably going to be well tolerated. If the answer is yes, we have to think about that a little bit more. There's also predictive models in databases like ClinVar, which can give you a score for that specific variant. And there are different thresholds where we think that, you know, like above 20 is likely deleterious, above 30 is probably deleterious in terms of impacting the protein function, essentially. And then there's large population databases like NOMAD. So NOMAD is specifically for autosomal dominant genes, and it's a large population database. Doesn't test everybody, but you know, it's a good subset of the population that's in this database, and it looks at whether or not we think we can predict using population-based variants in healthy people. If it's present a lot of times in that database in unaffected people, we think that's probably not the cause either. And because it's just a subset of the population, there have been a few different kind of papers and resources that have come out that really, if there's more than one person in these population databases that is healthy and has this variant present, it's pretty unlikely that that is the cause or that is a disease causing variant, but there's always caveats to that. And again, a negative or non-contributory test does not mean that there's not a genetic cause of the epilepsy. It's just not really one that we understand enough to test for yet. Now onto the yield of genetic testing in epilepsy. So of all of these different types of tests, which is the most useful? So a karyotype really only should be for ring chromosome disorders. Like if you're suspecting ring 20 for a patient with lots of like focal frontal lobe seizures, non-convulsive status, then you should get a karyotype because it's the only way you'll see it. But otherwise, it's really low yield. Only about 2% of the answers come from a karyotype. Microarray is a bit better, 8 to 10%. This is a test you'll want to think about for, you know, epilepsy plus like developmental delay, other types of things that you might suspect a deletion or duplication or something like that for on the chromosomal level. Epilepsy gene panels, our yield is going up now to 20 to 25%. Better, still not great, but better. And that these numbers are changing kind of constantly as we add more genes to these panels, we understand them more, testing gets a little bit better and cheaper. And so the yields, these are relatively recent yields, but these are subject to change. Whole exome sequencing, now we're getting a bit better even, 30 to 45% yield here. And whole genome sequencing, of course, if you're looking at the whole genome cover to cover, you're going to get the highest yield. So 50 to 60% with whole genome sequencing. There's higher yields in different patient populations. So a younger age of onset of the epilepsy is going to give you a higher yield of genetic testing. And there's also the highest yield in developmental and epileptic encephalopathies. So these are kids typically with epilepsy that's severe, difficult to control, who also have developmental delays, intellectual disabilities. Sometimes they can have developmental regression. So if you have one of these developmental and epileptic encephalopathies on the more severe spectrum, you're going to have a pretty high yield for genetic testing. And this is a really big meta-analysis, 103 studies, which was current through May of 2020. So relatively recent, not, like a lot has changed in the last 3 years, even for genetic testing, but still is a relatively good resource. And we see this category, DEEs is the developmental and epileptic encephalopathy, has a diagnostic yield for genetic testing of 38.8%. So pretty good. But there are also, aside from just yield, like which percentage is the highest to give us, we also have to think about cost considerations and time considerations. So genetic testing can be expensive. It's not as expensive as it used to be, but it can still be quite costly. And so gene panels, even though they're lower yield, 20 to 25%, which is still actually pretty good to get an answer. But you can often get this testing for free, especially in children under 9 years old. You can get free sponsored testing through a lot of different companies. And that's a great resource for a lot of our families to just get this free testing, and we can often get a result from that. Whole exome sequencing is more expensive, but it's increasingly being covered by insurance. Not always, but there's more insurance coverage for exome now. And then whole genome, of course, our highest yield test. Previously, it was like impossible to get whole genome sequencing. It was research only. Then it moved to inpatient only. But now, like just, even in the last month or two, there's been increasing coverage for outpatient testing. So, for people who live in Utah Medicaid is covering whole genome sequencing now for epilepsy, which is really exciting for us. So been getting a lot more of these, not on a research basis, but on a clinical basis, which is great. But these tests also take time. So gene panels are usually the cheapest, and they're also the fastest. Usually we can get results back in about 2 weeks. The upper limit of that is around 4, but really 2 to 3 weeks is pretty quick to get a result back. Whole exome takes longer, about 4 to 6 weeks. And whole genome, which there's a caveat to this, but whole genome takes about 2 to 3 months. So that's quite a while. If you think about you're reading the whole genome from cover to cover, that's a lot of data to get through and analyze. So it takes a lot longer. And only certain labs will do the whole genome sequencing. A caveat to whole genome sequencing is that we can do rapid whole genome sequencing as well. And that is a little bit more limited in what options you have for or which patients you can get that for. It's usually an inpatient ICU only type of population that we can get that. But the turnaround time for that can be 1 to 2 weeks. So that can be really quick to get back a rapid whole genome, depending on the clinical kind of picture and scenario. So why do we do genetic testing? I've talked a lot about the yield. I've talked a lot about the costs. Why do we do these expensive tests? What is the point of this? So it's really important to think about it from the family's perspective. So providing an answer to some of these families that have been searching for years and years, not understanding why their child is this way, what is the cause of the epilepsy, what is the cause of the developmental differences, autism, that can be a big positive for the family to understand that diagnosis. And there are sometimes potential targeted treatments. I'll talk a little bit later about antisense oligonucleotide therapy for SCN1A, which is an exciting development. But there's lots of emerging genetic therapies. There can be sometimes associated symptoms, conditions. There can be like renal anomalies, cardiac malformations, things like that that are associated with specific genetic changes. And then we can facilitate early screening for these issues before they become a problem for the patient. Prognostic information is also something that can be very powerful for families to understand, like what can we expect for my child's epilepsy, for their development, for their like functional status in life in the future, based on what we understand about other children with this specific genetic change. Sometimes that information we have is pretty limited and it's sort of, like variable and patient by patient, case by case, and we can't always give a concrete answer, but even having some background can be very powerful for these families. And another very powerful thing for families are all of these support groups for rare disorders. And most of the different genes actually have their own support groups, but there's also just, like the like rare epilepsies and rare genetic disorders kind of groups, kind of more globally. But these are just some examples: Dravet Syndrome Foundation, TSC Alliance, that we have for different genetic causes of epilepsy, that families can connect with other patients and other families who have children affected by these disorders. There is also important kind of family counseling in terms of recurrence risk if these changes are inherited or not. But if there's a risk for future children, like siblings of the affected child in that family, or for the child to pass on to their future children themselves, the patient themselves to pass on to their future children. So there's important kind of family planning implications of this too. So I hope I've convinced you that it's important. And so now the incidence of genetic epilepsy. As we understand more and more about genetics and genetic causes of epilepsy, the incidence of identified genetic causes of epilepsy just keeps going up and up. So right now, kind of wide range, but about 20 to 50% of patients with epilepsy will have an identified genetic etiology. Again, that is rapidly changing as we have more access to testing, more expanded testing, as we understand more about genetic causes of epilepsy. And when there is no known etiology of the epilepsy, many of those patients are presumed to have a genetic epilepsy that we just don't understand enough about yet and know how to test for yet. We know that there's increased risk for epilepsy in families, even without an identified genetic cause. So this is kind of this big table here, but when we look at all epilepsy, there's a 3.3-fold increased risk for first-degree relatives to also have epilepsy. And it varies a little bit by seizure type. Like postnatal causes are probably more structural and acquired, but if we think about idiopathic or like when we don't know the answer, 5.5-fold increase. Generalized seizures that we don't know a cause for is 6-fold increased risk for first-degree relatives. So even though we don't always know the specific genetic change, we know that there's an increased risk for first-degree relatives and families to have epilepsy syndromes. And the caveat of that, is also that many of the genetic changes we understand are de novo, meaning new in the patient. Now we'll talk a little bit more about specific genetic causes of epilepsy. So when we think about kind of the very rapid kind of here in the 2000s era of genetic testing and genetic or gene identification, but thinking all the way back to 1994, we had the first epilepsy gene identified here, TRNA4. There was a little lag here, but then in the channelopathy era here, we had more sodium channelopathies, potassium channelopathies, GABA kind of chloride channelopathies that were discovered. And there's this little kind of uptick here in the late 90s, early 2000s, and it kind of peters out again. And then kind of the 2010s, some more micro deletions, but then as we're getting more next generation sequencing, there's just this explosion of genes. And this is now, kind of an outdated reference, it's from 2016, but you can imagine this is just continuing to go up kind of logarithmically in terms of the numbers of genes that have been identified. And we can see this a bit more. This is a nice figure from Alyssa Yasowitz and Solomon Moshe from 2022, so relatively recent. But when we think about these genes kind of grouped by age of onset of these genetic disorders, this genetic epilepsy disorders, we can see tons and tons of genetic causes, which I won't go over this kind of in detail, but I've pulled out some kind of highlights based on age of onset of the epilepsy. So neonatal age of onset of epilepsy, my focus is really more on like neonatal and infantile onset genetic epilepsies. So this is more my wheelhouse, but neonatal onset genetic epilepsies can range from like severe to more self-limited. These are the new terminologies that we've kind of laid out by the ILAE. It used to be benign familial neonatal seizures. Now it's self-limited neonatal epilepsy. But we see some overlap here, and we'll get into this more between KCNQ2 with both the more severe onset, the early infantile developmental and epileptic encephalopathy, or EIDEE, of which genetic etiologies are identified in over 50% of babies who have this severe difficult to control early onset epilepsy with developmental delays. And KCNQ2 is a major cause of this, SCN2A. So KCNQ2 is a potassium channelopathy, SCN2A is sodium channelopathy, but we see kind of other genetic causes here. I've just bolded the most common. But then there's self-limited neonatal epilepsy that has a very good prognosis. One of the other names for this is fifth day fits, where babies have an unremarkable kind of prenatal and delivery course. And then around day like 3 to 7 of life, they come back and they have these focal, usually tonic or tonic-clonic focal seizures. And so that may very well be a self-limited neonatal epilepsy. And then when you ask the parents if either of them have had epilepsy in infancy, often they say, no, of course not. And then you ask the grandparents and they're like, oh yeah, he did have seizures when he was a little baby and then he outgrew them and he was fine, which is usually kind of a story that you might get commonly for this. And those are really more the potassium channelopathies, or KCNQ2 and 3. Then we move on to infantile onset, so self-limited familial neonatal infantile epilepsy, which is just a little bit later onset than the neonatal epilepsy. SCN2A, which we saw here actually, SCN2A is also something that we can see in both EIDEE and SELMI, the self-limited neonatal epilepsy. So lots of phenotypic variability here. But SCN2A, KCNQ2 again, another common player. And then we get a little bit older, somewhere in like the 3 to 12 month range, with self-limited infantile epilepsy, SELMI. I think SELF-NI is actually a really funny one too. Self-limited familial neonatal infantile epilepsy. Who came up with these abbreviations? But self-limited neonatal epilepsy, PRRT2 is a major cause. And actually, PRRT2 is one of the most common causes of genetic epilepsy in childhood. So an important one that we'll talk a little bit more specifically about later, but also some of these potassium channelopathies. Myoclonic epilepsy in infancy, which is a more benign epilepsy, doesn't currently have any known causal genes, but interestingly, there's a family history of febrile seizures in about 10% of cases. And then genetic epilepsy with febrile seizures plus SCN1A is a main cause, but there's also SCN1B, HCN1, which is a different kind of chloride channel. And that's an important one that may come across as just the child starts as febrile seizures. And you think, okay, great, they have just run-of-the-mill febrile seizures. This isn't going to be a problem. And then as they get a little bit older and continue to have febrile seizures, that are relatively more frequent than we might expect, then they start having afebrile seizures as well. And that should really be like a clue. Okay, well, this is not really just febrile seizures anymore. And there is a relatively high yield of actually genetic diagnoses in GEFS plus, usually SCN1A. Then epilepsy of infancy with migrating focal seizures. So now this is stepping into kind of more severe epilepsies versus the first four categories were more benign. So epilepsy of infancy with migrating focal seizures is a early onset severe epilepsy with multifocal seizures. You can actually see in the EEG sometimes there are simultaneous seizures happening in different locations at the same time. Overall a poor prognosis, but KCNT1, which is a potassium channelopathy, is the most common cause. And you can see many other causes here. Infantile epileptic spasms syndrome, which is kind of the all-encompassing term for infantile spasms, West syndrome, any of the kind of, it's the umbrella term that makes sure we capture all of the babies that have infantile spasms, essentially. There is an identified genetic etiology in about 41% of cases, but really we can, as more expanded testing becomes more available, I imagine that percentage will just continue to go up. But spasms are associated with trisomy 21, ARC, CDKL5. There's lots and lots of tuberous sclerosis, lots and lots of genes that are associated with infantile spasms. And then Dravet syndrome, previously known as severe myoclonic epilepsy of infancy, that is almost or very frequently in 80 to 85%. So in the majority of cases is caused by variants in SCN1A. And we'll talk a bit more about SCN1A, but there are also other non-SCN1A genetic causes of Dravet syndrome. Then thinking about childhood, and I'll try to run through these quickly, but epilepsy with myoclonic atonic seizures, DOSA syndrome, has quite a few identified genetic etiologies that we understand now. Epilepsy with eyelid myoclonia or Jevons syndrome, we don't really have strong associations with genetics with this. We think it's polygenic, and we think there is likely an underlying genetic cause. And there are a few genes that have been described in a few cases, but it's not one that we really understand a lot of causative genes for yet. Lennox-Gastaut syndrome is a really big bucket term, essentially for any child with refractory epilepsy with multiple seizure types and developmental delays or differences. So it's not really, saying someone has Lennox-Gastaut syndrome doesn't really tell you anything about the etiology of that. But there's lots and lots of genetic causes of Lennox-Gastaut syndrome. Many. Childhood absence epilepsy, there are some identified genetic changes, particularly with early onset absence seizures with GLUT1 deficiency. We'll talk about that more a little bit later. Epilepsy with myoclonic absences, most likely is polygenic. Panniatopolis syndrome, the new name for which is self-limited epilepsy with autonomic seizures, or CELIAS, is also likely polygenic, but rarely actually is associated with SCN1A, which is interesting. SCN1A can basically do anything. Childhood occipital visual epilepsy and photosensitive occipital lobe epilepsy, these are kind of more on the benign spectrum in children, likely polygenic, but there's a positive family history in 1/3 of patients, which is interesting. Self-limited epilepsy with centrotemporal spikes. This syndrome has gone through so many name changes, I can't even keep up anymore, but the most recent one is SELEX, but it's usually benign epilepsy with centrotemporal spikes, childhood epilepsy with centrotemporal spikes, benign Rolandic epilepsy, all the same thing. Likely is polygenic, but there have been some cases associated with GRIN2A variants. Oops. Epileptic encephalopathy with spike and wave activation in sleep, which is basically where the sleep record is taken over by spikes, occupying more than 85% of this sleep record, has been associated with GRIN2A as well. Autosomal dominant nocturnal frontal lobe epilepsy. So these can be sometimes mistaken for night terrors, nightmares, things like that, because they can be very hypermotor, where the child basically has seizures out of sleep and just is like having bicycling movements, kicking movements of their legs, or just kind of like thrashing in the bed, those kind of things. So things to think about, that frontal lobe seizures can look very strange in terms of their semiology, but we do have some identified genes for those as well. And also interestingly, hypothalamic hamartoma, about 5% have a genetic, an identified pathogenic variant in GL13. Adolescents, it's kind of a grab bag. Most of these we think are polygenic. Most of the adolescent onset epilepsies are generalized, and most of them we think are polygenic. So JAE, juvenile absence epilepsy, JME, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures alone. But then as we get to more focal epilepsies, we have more identified genetic changes. So epilepsy with auditory features, which is temporal and location, usually LGI1 is an important gene to know for that one, as well as familial temporal lobe epilepsies, LGI1, DEPDEC5, and the LGI1 gene is not to be confused with the LGI1 antibody, which can also cause epilepsy and autoimmune encephalitis. Familial epilepsy with variable foci, DEPDEC5 and PRL203, we'll talk about a bit more later. Oops, okay, great. So that's adolescence. And now let's go through some specific genes. So PRRT2, again, very common cause of epilepsy in childhood, and it can cause a few different phenotypes. So most of these examples I'll show you will have a few different phenotypes. It can cause benign familial infantile seizures, again, between like 3 and 12 months. Usually epilepsy goes away by 24 months and they have normal development. So very good prognosis for this. It can also cause a movement disorder, paroxysmal kinesiogenic dyskinesia, where you get kind of these hyperkinetic movements that are precipitated when you move yourself. Like when you get up from standing from a chair and start walking, then you'll start to get these hyperkinetic movements. And those can happen independently of each other. And then you can also have them occur in combination. So infantile seizures and this movement disorder together. It's also described in hemiplegic migraine, developmental delay, intellectual disabilities in about 5% of other people. And it's a presynaptic protein. This is just an example. I'll probably skip through most of these visuals, but it's just demonstrating kind of when we look at these genes, there are extracellular domains, transmembrane domains, cytoplasmic domains, that we can see all of these different genetic changes. When I mention a gene, there are tons and tons of different described pathogenic variants that can cause the epilepsy, the movement disorder, or combined for PRRT2, for example. SCN1A has probably the broadest of all phenotypes. I haven't covered all of the different categories here, but kind of the big categories include Dravet syndrome, which is more severe. You can have febrile status epilepticus, essentially with hemiclonic seizures, and then progresses to multiple different afebrile seizure types, and there's progressive cognitive deficits that emerge after the onset of the epilepsy. GEFS plus, again, is milder. You can have unaffected carriers with this. You can have simple febrile seizures with SCN1A, or some just febrile and afebrile seizures that children tend to grow out of, but sometimes you can have more severe epilepsy with GEFS plus, so something to think about. And then there's actually an association with just febrile seizures with SCN1A, which is not something I think we always think about. There are really important treatment implications for SCN1A. Sodium channel medications are contraindicated. Phenytoin, carbamazepine, oxcarbazepine, lamotrigine, they can all worsen the epilepsy. And then we have specific treatment guidelines that we use for Dravet patients specifically, based on available data of what has worked well. This is one of the older identified genetic changes and also one of the most common. And there's also some genetic-based therapies under investigation, which I'll briefly mention. Again, for interest of time, I'll kind of skip over this, but lots of different genetic changes outside of the cell, in the transmembrane domain, inside of the cell, that can cause both Dravet, in the circles here, non-Dravet phenotypes in the squares here. And there are lots of different non-Dravet phenotypes again.
Yeah.
So treatment implications are something really important to consider when you are thinking about doing genetic testing, but specifically for Dravet syndrome caused by SCN1A, we think that Depakote should be used first line. There's a few medications second line that we should use. Fenfluramine is like a newer, exciting one that seems to be much more effective than our other standard medications for this. Cannabidiol, Epidiolex is an important treatment option for these patients as well. But most importantly, I think, is just to avoid these sodium channel blockers. And then there's antisense oligonucleotide for SCN1A associated Dravet syndrome. So this is a specific genetic treatment. And the response rates have been very promising for this. We see after 3 months, there's an 80% seizure reduction, 6 months, 89% seizure reduction at this kind of higher treatment dose of the antisense oligonucleotide. So this is still preliminary data, and this only really has gone through phase 1 and 2 testing, but we're all anxiously awaiting phase 3 of this trial to open. KCNQ2, again, has kind of like 2 main phenotypes. One is very benign, formerly benign familial neonatal epilepsy. Now it's self-limited neonatal epilepsy, or CELNE, and those patients generally do very well. The majority do not develop epilepsy later in life, but a subset, about 10%, will develop seizures later, but generally they have normal development and have a good outcome. Versus KCNQ2 related early infantile developmental and epileptic encephalopathy are neonatal onset seizures that are very difficult to control. There is developmental delay. EEG can be very abnormal with burst suppression, and though seizure frequency decreases with time, there are generally very poor developmental outcomes. KCNQ2 is also related with infantile spasms with onset within the first year of life. And again, this is part of a potassium channel. This is just kind of another illustration here where we can see that there are different areas or different identified variants, lots of identified variants that can cause here benign neonatal epilepsy, also here in panel B, benign neonatal epilepsy, versus more developmental and epileptic encephalopathy, but we see them in all of the kind of main kind of domains. TSC, tuberous sclerosis complex, is a genetic neurocutaneous disorder that essentially your body produces hamartomas or benign tumors of multiple organs, including the brain, the eyes, the heart, the lung, liver, kidney, skin. Seizures occur in over 80% and usually start young. And importantly, this is a very common cause of infantile spasms. 35% of patients with TS will have infantile spasms. There's a high burden of cognitive deficits and learning disabilities, autism, behavioral problems. This is just a graphic of all of the different kind of organ systems that are affected. These are the diagnostic criteria for TS, which I'll skip over in the interest of time, but this is another nice graphic here on the side from the Cleveland Clinic. And then I think this is hopefully the last genetic group that I'll talk about. But the Gator complex genes, which Gator 1 and 2 essentially are here. You can see TSC 1 and 2 actually related to this. RAG1 or RAG, the RAG genes also are affected here, but DEPDEC5 is part of Gator 1. These are all part of Gator 1 actually, and can cause multiple focal cortical dysplasias and familial epilepsy with variable foci. It can cause autosomal dominant nocturnal frontal lobe epilepsy, familial mesial temporal lobe epilepsy, so it causes a lot of different causes of focal epilepsies. Similarly, NPRL2 and 3 also encode a different subunit of Gator 1 and regulates this mTOR pathway, which is regulated in a separate arm by TSC. And I think the important thing to highlight is we used to not think that there were genetic causes of focal cortical dysplasias other than changes in the brain tissue itself, but now we know that there are actually somatic mutations in genes that can cause structural brain abnormalities like focal cortical dysplasias. So I do genetic testing for kids who have focal lesional epilepsy, like a structural change, focal non-lesional epilepsies, generalized epilepsies. Basically, most people will get genetic testing. One thing that I wanted to highlight is SCL2A1 or GLUT1 deficiency, glucose transporter 1 deficiency syndrome, because I think many people don't think about like staring or behavioral arrest or things like that in really young kids as being a sign of absence epilepsy, because it's just not the most common age group. Usually we see this in school age kids, like 6 to 8 year olds that have absence. But if you're seeing a really young kid with what you think are absence seizures, it's important to send them so that they can get genetic testing, because there's a specific treatment with the ketogenic diet that really impacts their outcomes later for epilepsy and their development. And so it's important to identify this and start treatment early. Another thing that we can see with GLUT1 deficiency are movement disorders that can sometimes precede the epilepsy. So, and there's like basically any kind of movement disorder can be seen with this. And then a last note here is on febrile seizures. Febrile seizures we know run in families. There's probably a genetic predisposition, but we don't know a lot about it because we don't test that commonly just for febrile seizures. But when we think about, there was this really large genome-wide association study in 2015 of febrile seizures. We did identify that there are associated genes with febrile seizures, and there probably would be more identified because, but we just don't understand enough about it yet, nor are there, I think it's really interesting, but we don't have, there's a lot of other developments that we can make that would have a greater clinical impact at this point. And because so there's relatively limited data on the utility of testing for febrile seizures alone. So in summary, genetic causes of seizures and epilepsy are common. They're being increasingly identified. The yield of the genetic testing is highly dependent on the test type and also the patient. But getting a diagnosis is very useful for prognosis, family support, family planning, and there are specific treatments available for a subset of genetic epilepsies, which we'll probably learn more and more about. There are common genetic epilepsy syndromes that can be categorized by age of onset. But I'd like to leave time, hopefully in the final few minutes here, for some questions.
Thank you so very much. That was a great presentation, great overview of so many genes, not all of them, right? We're still learning, like you said. There are a couple of questions that have popped up. So if it's okay, in the last couple of minutes here, I will just read those. One question about the slides being available. Are you okay if we post the slides with the recording?
Yeah.
So that people can access those. There was a question about that. And then also, I think you answered this in maybe the first slide, but what is the difference between epilepsy and seizure disorders? Do you want to just clarify that maybe one more time for people who came in late?
Yeah. So epilepsy is really just a term that we use to describe a disorder in which you are prone to having seizures, essentially. So someone who has seizures who we think is at least a 60% risk of having more seizures, basically. And that can either be because they've had at least 2 unprovoked seizures that will give you a diagnosis of epilepsy, or if you've had 1 unprovoked seizure and you have some other evidence either on your EEG with epileptiform abnormalities, on your MRI with structural abnormalities, that we think puts you at a higher risk to have more seizures, essentially.
Great. Thanks for clarifying that. And would there be any resource that you would point to? I think we have one of our primary care providers asking about specific information on like SCN9A, CHD2. Is there any place that you would point primary care providers maybe into getting more information about a specific genetic cause of epilepsy or seizures?
Yeah, I think it's really important to work with, like our genetic counselors, our epileptologists like myself, especially those who have a specific interest in genetic epilepsies, to really help families understand this and to appropriately like point them in the right direction. But kind of some general resources. The Epilepsy Foundation resource, I think, is always a really great starting point, or Epilepsy Foundation website, excuse me, which I think is actually just epilepsy.com. And that is a really great resource that has an overview of some of the different genes, but it can also link families out to kind of the main different family support groups. So if there's a specific gene like SCN8A or something like that, then that will link them out to that like SCN8A support group. Or if they have Dravet syndrome, like the Dravet Syndrome Foundation. So there are these kind of bigger foundations that do a lot of family advocacy and family support, for the specific different genetic types. But really, the Epilepsy Foundation is great as an overall resource for anyone with any type of epilepsy, and with any genetic epilepsy.
Wonderful. Thank you. And I'm just seeing that we're right at the top of the hour. And so I just want to thank everyone for coming. I know that you have to run off to another appointment. So thank you so much for your time today and your presentation. And I'm just going to remind everybody that's on the call that would like to claim CME for this event that there is a link in the chat for the form to fill out to claim that. If you would like to look there, you can see that link, and we will be sending out the recording after the event, probably in the next week or so. So thank you again, Dr. Sandoval-Carmarian. I really appreciate your time today and your presentation.
Yeah, of course. Thank you. Hopefully that was helpful for everyone. And it was great having the opportunity to chat with you all today.
Thanks so much.
Great. Thank you.
And just a reminder, everybody else, our next webinar will be in January on our last topic area. And just one last reminder to please join us for our Genetics Summit coming up in 2 weeks. And I'll leave that up there for a moment if everybody would like to scan that QR code to register. So thanks again. Talk to you later, everyone. Bye-bye.